In thoracic medicine, sometimes the absolute smallest things matter the most. We're talking about tissue samples, often smaller than a grain of rice, that hold the keys to a life-changing diagnosis. Everything from staging cancer to figuring out personalized medicine, it all hinges on getting the most information from the tiniest bit of tissue. And that's really the big question, isn't it? Minimally invasive procedures are the norm now, which is fantastic, but it means we as a medical team have to guarantee that every single precious sample gives us everything it's got. The pressure is on, from the person collecting that sample all the way to the pathologist reading it, to nail this process every single time. All right, so let's jump in. We're going to follow this tiny specimen's big journey, from the moment it's collected to the final analysis. And we'll be using the awesome guidelines from the College of American Pathologists as our guide. We'll kick things off with the main challenge, then talk collection, how to maximize our sample, what happens in the lab, and finally, touch on some special cases. First up, the small sample problem. You see, we're in this kind of weird spot in medicine right now. Our techniques for getting tissue are safer and less invasive than ever, which is amazing for patients. But at the exact same time, the amount of data we need from that tissue, especially for all this complex molecular and biomarker testing, has just gone through the roof. And this, right here, this is the heart of it all. It's not just about getting a diagnosis anymore, like, yep, it's cancer. We need predictive and prognostic data to actually guide treatment. So the challenge is providing all of that from a super limited amount of tissue. It's a huge task, for sure, but that's exactly what these guidelines are here to help us tackle. So where do we even begin? Well, it all starts in the procedure room. The choices that are made right there, the tools you use, the techniques you pick, they create a ripple effect that touches everything down the line. The two most common ways we get samples are fine needle aspiration, or FNA, and core needle biopsy, or CNB. FNA gives you cells, which is awesome for cytology. A core biopsy, on the other hand, gives you a solid piece of tissue, so you can see the architecture. Now, don't think of these as one versus the other. They're actually teammates. The right call just depends on the situation, the patient, the lesion, and what you're trying to find out. Now check this out. For EBUS-TBNA, which is a super common procedure for staging lung cancer, the guidelines are pretty flexible. They say 19, 21, or 22 gauge needles all work just fine. But there's a trade-off you got to think about. A bigger needle might get you more cells, which sounds great, but you also run a higher risk of getting more blood in there, and that can really mess with some of the later tests. For transthoracic procedures, it's a similar story. But that last point is absolutely crucial. For core biopsies, you want to try and get at least 3 samples. Why 3? Well, you have to think way past the initial diagnosis. You're trying to bank enough tissue for all the fancy downstream testing that modern cancer care requires. 1 or 2 just might not cut it. So you've got the sample. Awesome. But how do you know it's any good? How do you know you actually got what you were aiming for? This is where a real game changer comes in. Checking the sample right there on the spot, before the procedure is even over. It's called a rapid on-site evaluation, or ROSE, and you can basically think of it as a quality control check happening in real time. A cytopathology team member is right there looking at a bit of the sample under a microscope during the procedure to say, yep, you hit the target and we've got enough material. This is just huge for making things more efficient and safer for the patient. And the process itself is pretty simple. You make a smear from the fresh sample, give it a quick stain, and the cytotech or pathologist takes a look. But the magic is in that last step, communication. They can immediately tell the proceduralist, you got it, we're good to go, or nope, we need you to take another pass. It's instant feedback. And does it work? Oh yeah, just look at the data. In these studies on EBUS-TBNA, the diagnostic yield, basically your success rate, is consistently higher with ROSE. I mean, look at that first study. It's the difference between an 86% success rate and a perfect 100%. That is a massive difference, and it means fewer patients have to come back for a repeat procedure. Okay, but what if your hospital doesn't have ROSE? What do you do then? Well, the guidelines give us a really clear rule of thumb. For EBUS-TBNA, you should do a minimum of 3 to 5 passes. Just burn that number into your brain. Think of it as your safety net. It maximizes your chances of getting what you need when you don't have that real-time feedback. All right, so the sample's collected. It's a good one. Now our story shifts from the procedure room over to the lab. This handoff and everything that happens next is just as critical to making sure that sample lives up to its full potential. And that brings us to a really, really important step, fixation. Guideline 13 is about as direct as it gets. Core needle biopsies need to be fixed in 10% neutral buffered formalin. Period. This is the gold standard. It preserves the tissue perfectly so that all your follow-up tests, from IHC to molecular analysis, are actually valid. Get this wrong and you could ruin the whole sample. So what about cytology preps like your smears or cell blocks? This quote from the guidelines is key. Yes, you can absolutely use them for advanced testing, but, and this is a really big but, only if your lab has done its homework and run rigorous validation studies. You can't just assume a test that works on formalin-fixed tissue is going to work on a smear. Every lab has to prove it for themselves. Now, a lot of what we talk about is focused on cancer, but these principles of careful handling are just as important for other things, especially infectious diseases like tuberculosis. So, if you suspect TB, your game plan needs to be a bit broader. The guidelines say to collect separate samples for cytology, for microbiology culture, and for a TB PCR test. And for pleural fluid, using a liquid media protocol for the culture is key. Why? Because it helps you get results back way faster, which is critical not just for the patient, but for public health. Okay, let's wrap this up with 4 golden rules. First, use rows whenever you possibly can. It's your best shot at getting an adequate sample. Second, if you don't have rows, remember that 3 to 5 pass rule. Third, fix it right. Core biopsies go in 10% neutral buffered formalin. And finally, always, make sure your lab has validated its tests for the kind of specimen you're sending. And that brings us to the final and, honestly, the most important point. These aren't just rules on a page, they're actions that directly affect people's lives. So whether you're going to be the one collecting the sample or the one analyzing it, the real question is for you. How are you going to champion these best practices on your team? Because in this field, getting the small stuff right, well, it's everything.